Thank you. Thanks for inviting me. So we are going to discuss, well, not only ERG, just electrophysiology, indications and interpretations. We start generally when you have a suspected visual pathway dysfunction. This flow chart tells you how to investigate such a patient. We start with a pattern ERG. Now, we are given only 15 minutes, so I can't go to the basics. So each person must know what a pattern ERG is. And it's got a P50, a positive at 50 milliseconds, and a N95, which is called the negative at 95. So if that, we start with a PERG, pattern ERG. And if that is normal, we do a pattern VEP. So let's take the first scenario. The PERG is normal and the pattern VEP is normal. And then the diagnosis would be a functional visual defect. So this patient, a 13-year-old boy, came with vision of 624, complaining of poor vision for about 8 months. Visual fields were normal, the OCTs were normal, so there was nothing that we could detect. And the pattern VEP was normal, pattern ERG was normal as well. And then we did an objective visual acuity, which is also available with the VEP, and this showed that the vision was 6.6. So this was a non-organic vision loss. So the next set would be where the pattern ERG is normal, or at least the P50 is normal. So P50 is dependent on the ganglion cell input, and the N95 is the output of the ganglion cells. So if the P50 is normal, or the whole ERG is normal, we do still a pattern VEP, and if that is abnormal, the problem would be an ocular optic nerve dysfunction. So this guy, old lady, 51-year-old lady with only eye, sudden loss of vision in the right eye. There was a history of optic neuritis in both eyes, and the patient came to us with disc pallor. The left eye had pale disc as well. The pattern ERG, you can see that P50 is normal. If the P50 is reduced and N95 is reduced. Now, this is a complicated thing because if the N95 has been reduced for a long time, the pattern ERG, the P50 becomes abnormal with time as well. So only in very early optic nerve dysfunction that the N95 becomes abnormal, and yet the P50 is normal. So this patient, N95 was reduced, and the P50 subsequently becomes reduced as well. But if the problem is actually in the optic nerve, then the P50 implicit time is reduced, and if primarily the ganglion cell input is the issue, P50 times will become abnormal. So here you can see that the P50 milliseconds is within the normal lower range. So this is basically an optic nerve dysfunction, and the pattern VEP showed no clear positivity, and this is a optic nerve lesion. And if the there is another 66-year-old patient with bitemporal hemianopia, and here we did the pattern VEP, and this shows conduction delay in both optic nerves. And when there is a conduction delay, the possibility is demyelination. And if the amplitudes are less with a equal normal implicit times, the chances are that it's a conduction block. So this patient, there's a conduction delay, which means that the possibility is due to demyelination rather than compression. So this is useful to detect between demyelination and a compressive optic nerve lesion. Now the third possibility is where the P50 on a pattern ERG is reduced. Then we do not a VEP, but an ERG. And if that is normal, if the pattern ERG is normal, the PERG is normal, and the ERG, the whole retina is within normal limits, then it is a maculopathy. So let's see this patient who came, a 26-year-old female with gradually worsening poor vision. And you can see that there are RP changes at both macula with central flex. You can see that better with a red free, and better still if you do a autofluorescence, this shows it markedly well. So whenever you suspect a patient with Stargardt's disease, just do color pictures, as well as, even if you don't see very clear this picture, just get an autofluorescence done. This will easily demarcate the flex. And this is the OCT typical picture, atrophic macula. Early stages it may not appear this obvious, but this is how maculopathy, the Stargardt's disease will look. PERG was abnormal, P50 was normal. So this shows that this is a severe maculopathy. Full field ERG is normal. That means as a whole the retina is normal. Both scotopic and photopic responses are normal. And multifocal ERG would be abnormal when you think it's a maculopathy. So the diagnosis would be Stargardt's disease. Well, the next possibility is when PERG is the P50 is reduced and the ERG becomes abnormal. Now this happens when the whole retina, not only the macula, but the whole retina is abnormal in some way. So this is basically a generalized retinal dysfunction. Let's take this boy, 15-year-old, presented with night blindness, hearing deficiency, has already had a cochlear implant. You can see typical picture of retinitis pigmentosa with attenuated vessels, peripheral changes. In young people, you may not see the pigmentary changes to that extent, and you might just see salt and pepper appearance actually, and atrophic macula. So P50 was abnormal, most probably Usher's syndrome with the hearing defect, and the full field ERG shows an extinguished, full ERG is extinguished bilaterally. You can see the flat scotopic, both the photopic and the scotopics virtually flat. So this is retinitis pigmentosa. Now, extinguished flat ERG can be seen in severe retinitis pigmentosa, cancer-associated retinopathy, Leber's congenital amaurosis, which is somewhat like retinitis pigmentosa, a total detachment of the retina, ophthalmic artery occlusion, and siderosis. So siderosis also, it will be useful to do ERG to see whether there is siderosis when you are not sure. So this patient, a non-alcoholic chronic liver cell disease due to Wilson's, night blindness for 2 months. OCT was somewhat normal except for perhaps an epiretinal membrane in one eye. Bilateral rod responses are extinguished. You can see that in the scotopic dim light, the B wave is not there. So that just means that the rods are not functioning at all. You could also see in the photopic that slightly delayed cone responses. This is consistent with the rod cone dysfunction, perhaps due to vitamin A deficiency, and we have treated this patient with vitamin A. Then this patient, a 21-year-old, blurring of vision for 10 years. There was a history of some laser treatment. Vision was 618. You can see in the macula a bilateral cartwheel appearance, which is typical of, and also in the periphery we could see vitreous veils and laser scars to retinoschisis. So the OCT is typical of juvenile retinoschisis. And when you do an ERG, you get what is called a negative ERG, the B wave is smaller than the A wave. Ideally, it should be more than 1.5 times the size of an A wave. So the B must have a positivity more than the A. But if it is less than 1.5, you could say that the B versus A ratio is abnormal. And in this case, a typical negative ERG. This is typical of phototransduction dysfunction. So the ganglion cells are abnormal. The photoreceptors that give the A wave is normal, and the bipolar cells are abnormal. So there is no conduction beyond that. So this is due to post-transduction dysfunction causes a negative ERG. So this is X-linked juvenile retinoschisis. Now, negative ERGs you can get with X-linked retinoschisis, congenital stationary night blindness, retinitis pigmentosa sometimes early, cone rod dystrophy sometimes, and then central retinal artery occlusion, ischemic central vein occlusion, melanoma associated retinopathy. Remember, melanoma associated retinopathy gives you a negative ERG, and a cancer associated retinopathy gives you a flat ERG. So this patient, two patients actually, 20 and 11-year-old came with poor vision, severe color vision defect, and bilateral bullseye maculopathy in the elder sister. You could see that better on autofluorescence. And in the OCT, you can see optically empty areas. This is due to loss of ellipsoid layer inner segment. This is again typical of cone dystrophy, and PERG was abnormal. The multifocal ERG was abnormal. You can see that the full field scotopic ERG, which looks at the rod responses, are mostly normal, and the photopic responses, which looks at the cones, are totally abnormal. So you can see that this is consistent with our primary tentative diagnosis of cone dystrophy. The last scenario would be whether the PERG could be abnormal or normal, and the ERG is normal or abnormal, but the EOG is abnormal. So this is done when we have a doubt whether this could be Best disease. So this is a 34-year-old lady doctor who presented with this clinical picture. The right eye virtually like a pseudo-hypopian stage. Left eye has a mottled appearance. In the hyper autofluorescent central lesion, and you can see the typical Best disease characteristics on the OCT. PERG was reduced. Multifocal ERG, there was reduction in the macular cone responses. ERG, the full field ERG, both photopic and the scotopics normal. But the EOG is, there is an absent light rise, which is the light peak to dark trough ratio, which was about 1.1, which is abnormal, and this confirms the diagnosis of Best disease bilateral. This is another interesting patient who came with just one eye, having a typical Best pattern. The other eye seemed normal, and it's a unilateral vitelliform lesion. You can see that that's the autofluorescence, which highlights the fact the other eye absolutely normal. But when you do the PERG is abnormal bilaterally, the full field ERG as expected is normal, but the EOG is 1.3, which is consistent with Best disease. And mind you, both eyes you can see that it's only 1.3. So just because you don't see the lesion, the Best disease lesion, the RP dysfunction is there in both eyes. Now this one, a 16-year-old girl, gradually worsening poor vision, came with this picture, diffuse alterations of the RPE, yellowish multifocal subretinal deposits in a ring-like fashion in both macula, somewhat asymmetrical, extending to mid-periphery only. And this is the autofluorescence, and this is the OCT, which is somewhat like the Best disease characteristics. The fluid is in the interdigitation zone. There was no CNV, we did angioplex. PERG was reduced. Full field ERG was mostly normal, but the electrooculogram showed that this is 1. So there is most probably is autosomal recessive BEST disease, and that is the typical picture that you get with autosomal recessive BEST. Remember that, don't treat them for CNVs. And this we confirmed with genetic testing and confirmed that this was an autosomal recessive BEST. So I think time is up. And this one is actually a ring-like lesion, just like that is a adult vitelliform dystrophy where the EOG is about 1.7. So the similar picture, if the the Arden ratio is around 1.7, it most probably is adult vitelliform. So in summary, when you do a PERG, if it's normal, do the VEP. If it's abnormal, do the ERG. This helps us to diagnose what's wrong with the patient. Thank you.